To our virtual open house for the newly diagnosed with uveitis. I'm Frances Foster, the Foundation's Uveitis and Ocular Inflammatory Disease Support Group Chair and Facilitator. I will be moderating the evening for this event. The virtual open house is sponsored by the Clarity Study and presented to you by the Ocular Immunology and Uveitis Foundation. This is a 501c3 not-for-profit, tax-exempt organization founded in 2005 by Dr. C. Stephen Foster, pioneer in ocular inflammatory disease and uveitis. Our mission is to find cures for ocular inflammatory diseases, correct the worldwide deficit of properly trained ocular immunologists, and to provide education and emotional support for those afflicted with ocular inflammatory diseases and their family members. I'd now like to introduce Allison Justice, our Director of Development and Programs, and she'll talk about our upcoming events.
Thank you, Frances. And before I get started, I just wanted to thank Taryn Smith from the Clarity Study of Private for their support tonight. And not only tonight, but they're an all year round sponsor and helping us bring our community really important educational initiatives. I want to thank Andrea and Mia, Dr. Gonzalez, Dr. Anisi, for their support tonight, and always for all those who are new to our community, please be sure to visit our website. We have just tons of resources on our website. Please be sure to visit the different support groups we have to offer. Our last virtual support group is December 10th, and the theme is Let's Talk About It for caregivers. And be sure to check out in 2025, we'll have 12 more support groups coming your way. I'd be remiss not to mention our upcoming annual online auction. That's from Friday, November 29th through December 6th this year. And it's just in time for the holidays to support our cause and get some great items for your loved ones. So thank you so much all for being here.
Thank you, Allison. So we have a great meeting tonight. Our meeting is going to follow our ocular guide to ocular inflammatory disease, and it's going to cover topics with signs and symptoms of uveitis and ocular inflammatory disease, the diagnostic process, its correlation with autoimmunity, define autoimmunity, treatments, and support and coping. This meeting is being recorded and will be made available to view online on our website at uveitis.org. And now I'd like to show you our panel of speakers. We have a great panel tonight, from uveitis specialists to our mother-daughter patient caregiver duo, Andrea and Mia. I will be giving their bio before each of their talks this evening. Now I'd like to turn it over to Taryn Smith. She is the patient engagement manager at Private Therapeutics. Taryn is an experienced clinician with almost a decade of experience caring for patients in the fields of immunology, asthma, and allergy, as well as other fields of urogynecology and psychiatry. Before becoming a physician assistant, she worked for the Oklahoma Medical Research Foundation and served as a Fleming Scholar. Taryn holds a Bachelor's of Science in Nutrition from Oklahoma State University and a Master's of Health Science from University of Oklahoma Sciences Center. And I'll turn the meeting over to Taryn, who will present to us the Clarity Study, and we're super grateful for Priovents sponsoring this meeting. I'll stop sharing my screen and turn it over to Taryn.
Thank you, Francis. And thank you all for taking time out of your evening to come join us. Like Francis said, I am Taryn Smith. I'm a physician associate by background, and I work with Priovant Therapeutics, which is a very small but mighty team working on developing new treatments for rare autoimmune conditions, specifically non infectious uveitis being one of those. And so I'm just here to share a couple of slides about our global clinical trial that may be of interest to some of you. It is called the Clarity Study. Let me just screen share here. There we go. Okay, can everybody see these slides okay? Move this out of the way. Yeah, okay, great. So this is the branding that you'll see if you're looking for us. This is the Clarity Study. Very brief overview so you can get a sense of if this trial might be of interest to you or someone that you love. The Clarity Study is global. It is testing a once a day tablet called brepocitinib, which you do not have to memorize. But it's a tablet that hopefully will improve the inflammation and some of the bothersome symptoms that we see in non-infectious uveitis. The trial is slated to last up to 2 years, although it may not last that long for everybody. Um, this is a JAK inhibitor medication, which some of you may be familiar with and some of you may not, and that's totally fine. Part of my role here is to chat with folks one-on-one who are interested in this clinical trial and help you understand the medication that we're investigating or testing in this trial, and all the other details, all the other questions that you might have about the trial. But basically, it's a new kind of JAK inhibitor, which I'm sure Drs. Anisi and Gonzalez and many others could speak more to. There is currently not a JAK inhibitor FDA approved to treat non-infectious uveitis. This is a phase 3 clinical trial, so we're hoping to gather data to help prove or disprove whether or not the medication is helpful. But to date, we've had a smaller trial with the same medication in non-infectious uveitis. That trial was called the Neptune study. If you are looking for a little light bedtime reading, that can be a good read. Like all of our clinical trials, for everybody who is eligible, we provide full support to get you involved in the trial. So that includes very practical things like your transportation to and from all of your trial visits, food and accommodations if those are needed. And that support is provided for not only the patient or the person living with non-infectious uveitis, but also for their care partner. And we don't make you prove that you need a care partner. So if you just feel more comfortable having somebody with you at those visits, their expenses would be taken care of as well. And then, like I mentioned before, this is a global trial, so all over the world, sites are available, but many sites are already recruiting and enrolling patients for the Clarity study in the United States. So if you're interested, I would love to hear from you. This is a brief video about the study itself that is available on the website, clarityuveitis.com. Allison, do we have time to watch the video? It's about 2.5 minutes long.
Sure.
Okay, you got it.
Their volume.
You guys can't hear the volume?
No.
Okay, then we are not going to watch the video. If you would love to watch this video, you can find it on the website, clarityuveitis.com. Thank you, Allison, for giving me a heads up that the audio.
Of course.
Okay, so if you would like to chat with me one-on-one about your history living with uveitis and find out some more details of the trial, that is what I am here for. You can connect with me by going to the study website, clarityuveitis.com. Several places throughout that page, there is a button that is purple and it says either join now or check if I'm eligible. all of those buttons lead to me. So you answer 4 easy questions: your name, your date of birth, what country you live in, and if you've been diagnosed with uveitis. Then you will be taken to my calendar. You can choose a day and a time that works for you to chat. And yeah, I like to remind people I don't get compensated based on how many people enroll. My job is literally a reflection of Priovant's dedication to making clinical trials more approachable and understandable to patients. So if you are interested, you have any questions, I would love to chat with you. Please go to the website, sign up for a time, and I'll meet you there.
Recording in progress. Karen, so someone actually has asked, there's some questions in the chat, but I think let's hold our questions to the end. How does that sound?
Yeah, that's great. I'll be around. And I'll
Yes.
make sure you all have a way to contact me at the end of this webinar.
Excellent.
This is a very quick view of where open sites are now. I will say this is not all inclusive. Sites are opening, I would say, fairly regularly at this point. So if you don't see a location here that's close to you, don't despair. Please reach out and let me help you figure out if there could be another site in your area that's coming down the pipeline. Okay, so with that, I will stop sharing. I'll turn it back over to Francis, and thank you so much for your time and attention tonight, everyone. I'm excited to listen to our experts.
Thank you, Taryn. Thanks for being here.
Thank you, Taryn. Okay, now moving along with our meeting program, I'd like to introduce our first speaker, Dr. Stephen Anesi. He is co-president and partner uveitis and cornea specialist at Massachusetts Eye Research and Surgery Institution, which we abbreviate as Mercy. Dr. Anesi earned his doctorate of medicine at the Keck School of Medicine at University of Southern California in 2006. He completed his ophthalmology residency at Nassau University Medical Center in New York in 2010, where he served as chief resident. Dr. Anesi completed his fellowship in ocular immunology and uveitis at Mercy with Dr. Foster in 2011. Upon completion of his fellowship, Dr. Foster thought he was so talented, he invited him to join the medical staff at Mercy. He then became an associate partner in 2016 with Dr. Foster, and then in 2021, co-president and co-owner of Mercy. He has a long 14-year history of seeing and treating patients with all sorts of ocular inflammatory disease, from the front to the back of the eye, as well as surgery. Dr. Anesi continues Dr. Foster's legacy with publishing and is a preceptor for the Foundation's research and clinical fellowships in ocular immunology and uveitis. And now I'd like to turn the meeting over to Dr. Anesi, who will begin the program with introduction to ocular inflammatory disease.
Thanks, Francis. Good evening, everyone. Thanks for joining us. Hopefully everybody can hear me okay. Please let me know, somebody who can hear me, if there's a problem. I've been tasked to talk about a few things that are outlined in our guide. For anybody who's ever been to the practice or familiar with somebody who has been to the practice, for new patients that come, like to educate people on not only what we do, but just about the types of things that we see in general. Being a tertiary care center in ocular inflammation, which includes more.
We don't hear it. I don't hear you.
Lost your audio.
Dr. Anesi, we lost your audio.
I think he's frozen.
He is frozen. So while we're waiting for him to come back, the Guide to Ocular Inflammatory Disease, you can find that on Amazon. It comes as Kindle version and also as printed version. And you can go to our website, uveitis.org, go to books and publications, and it'll bring you to our Amazon author page.
I'm back.
You can find that. Great.
My Wi-Fi does not seem to be good tonight, so hopefully it doesn't keep going out. I'll try to get through this so it doesn't crash again. That actually got on really quick. Um, but anyways, yeah, like Francis was saying, this is available elsewhere, not just at our clinic, and she can talk more about that later. But I wanted to go through some of the points in the beginning of the book that are an introduction to, what we see and what we treat. There's several different bullet points here, and I'll go through my interpretation of these things. Ocular inflammation and ocular inflammatory disease in general, I kind of said a little bit of a summary of different types of those conditions. Basically, anything that's inflammatory that affects the eye or anything around the eye. So inflammation is kind of defined by
It looks like we lost him again. Do you want to step in, Francis?
Sure, I'm not sure if he continues to have problems, should we rely on Dr.
Do you want to go through these bullet points or just start going through them while we're waiting?
I think we probably should wait for Dr. Nisi to get back, but I'm not sure if we want to turn it over to Dr. Gonzalez if
I
he
think that's a good idea. Yep.
to have problems. But I'm not sure what Dr. Nisi was going to speak about. I do now have the guide in front of me, but as he was saying, inflammation, means setting on fire, can develop in any part of the body, but we're focusing on ocular inflammatory disease. There are over 85 different systemic causes of ocular inflammatory disease. And some of it is what we call idiopathic. So that means that we don't know what the cause is. It is autoimmune still, but we just don't have a systemic cause. Okay.
I transitioned back to the phone. The laptop and the Wi-Fi here is not happening. So the phone should be hopefully good enough. Hopefully everybody can see me, right?
Yes, it's fine.
Yes, I just gave them a little overview over 85 different systemic causes and idiopathic definitions. So.
Okay, so exactly right. And not all the diseases that we can find an exact cause. And sometimes people really get hung up on that. And I tell them it's okay. The main things that we're trying to do at the beginning of trying to figure out what's going on is to first introduce people to what they have, what we think they have, and then trying to find the reasons why or why they don't have something, and rule out things is basically what I'm trying to say. If you can find and look for the common causes, even if you don't find them, at least you've seen what is not going on. So for example, a lot of people come in, if they come in with uveitis, we'll do a lot of studies on common infections that may or may not be involved. If we don't find evidence that those infections are in play at all, then we can at least be confident that those are not the cause. And that helps us limit then and narrow down the diagnosis to something that's non-infectious and inflammatory, meaning that's almost certainly an autoimmune problem. There are other causes of inflammation as well, or things that look like inflammation, so-called masquerade syndromes, that can be causes of people having certain diagnoses in their eyes. That can include things like trauma, post-surgical, and those are both technically non-infectious inflammatory problems as well. Some people even have malignancies and cancers that look like inflammation, and to be honest, cancer can have an element of inflammation that responds like inflammation as well. And we have an idea of whether those things are more likely than not. And to be honest, most of the people that we see, the overwhelming majority of the people that we see, like 99% of people that we see, don't have those problems, but we just have to keep them in mind. Most of the things that we see are autoinflammatory in our practice, and or may have a dual component, may have an infectious and an autoinflammatory component, because that can certainly happen as well. What is the inflammation? I think I was talking about that before my computer died. For example, like this autoimmune inflammation is when the body is out of control. The regulation of inflammation has going past what it's supposed to do. The body has a system of being able to control things within itself to protect it, and it uses the inflammatory system to do that. So if you have a foreign invader, a bacteria or infection or something like that, even tumor cells are considered not things that they're supposed to be in the body. The immune system is what helps to guard against those things. But if there is something in the body that is accidentally misrepresented as something that's foreign, then the immune system will act as if it's foreign and attack it and cause inflammation. Inflammation not only heals cuts, but it also can cause damage in the way of swelling and pain and to areas that it affects. And when it affects things like joints and skin and other parts of the body, those things tend to bounce back really, really easily a lot of the time. Joints, things like that. But when the eyes get affected, they can be severely affected very quickly and may not bounce back as easily because of the structures being so fragile and intimately organized. And longer term effects of even short term chronic or severe inflammation can be pretty detrimental. So we like to get on things pretty quickly, and we like to try to not waste any time getting people under good control and trying to find out what the cause of the disease is. So I went over a little bit about what inflammation is, what autoimmunity is. Again, that's our body attacking itself in an irregular way. Autoimmune mediated ocular inflammatory disease is just that, when it's affecting the eye. And so you have different parts of the eye that can be inflamed. You can have the uvea, which is the middle layer of the eye, and the wall of the eye, including the iris and the choroid and the ciliary processes. That's not something we think about when we think about the eye. Usually we think of the shape of the eyeball, maybe the cornea is the clear window, the lens and the cataract. People are pretty familiar with that. The retina, people know about that. Those are more commonly known parts of the eye, but the uvea is not something you always think about. The iris is probably something that more commonly thought about. That's part of the uvea. So those are different parts of the eye that can become inflamed, including the surface tissue, the conjunctiva, or the white ball of the eye, the sclera. All of those things may be inflamed, and they call those things itises. Itis is a suffix of words in our language that means inflammation. So if you have retinitis, it's inflammation of the retina. If you have keratitis is inflammation of the cornea. Keratosis is referring to that. Uveitis is inflammation of the uvea tract, or the uvea, and so on and so forth. All these names basically refer to inflammation of different parts of the eye. And you can have a combination of these things as well. So if you have the sclera and the cornea inflamed, you can have sclerokeratitis, and you kind of mix them together. Anyways, those are things that we use as conventional names to define things in our notes. And I know they're big, long words, and not everybody has an appetite for that type of thing, but it helps us more closely define things medically, and so that we can help to target things, and it helps us in our research, it helps us in our studies, and it helps us to communicate with other doctors as to exactly what problems are going on, and so we can help to identify things. And the symptoms of these problems, many of you may be familiar with.
I think you just went out again.
He was doing so good.
I know. Lost him.
Allison, should I answer some of the questions in the chat while we're waiting?
Sure, that's a great idea.
Okay, you bet. So to answer the first question, Stanford is the only location for the Clarity study that is touching the bay. However, there are sites in Modesto and Sacramento. So I hope that's helpful. Again, if you have any more questions about that, I would love to chat with you. I will shortly here drop my email address and my cell number in the chat. Just please know that the cell that I'm dropping there does not accept text messages. Okay, let me get the chat back up here and just tell me when I need to stop here. Jose, you have great questions here. What is the endpoint of the study? So one of the major things that the Clarity study is looking for is time to flare. So most people who are living with uveitis at some point, oh, there's Dr. Anisi. I'll be quiet.
I came back. Sorry so much about this completely terrible connection I seem to have, which never actually exists in this place otherwise, except for, oh, I see people moving. Okay, good. I'm almost finished anyways, which is good. Symptoms like I was going over, pain, redness, floaters, light sensitivity, decreased vision. And again, those represent different parts of the eye that become inflamed and have different functions. So like an example, then the iris is reacting to light. It constricts or it dilates and it becomes inflamed. And if you go into a light and it constricts, it's a muscle that's inflamed, it'll become painful. Similar, like if you've ever had tendonitis, I got that once when I was playing baseball as a kid and just moving your arm, it hurts a lot. So you have to rest the muscle. And that's why we give medications that help to relax parts of the uvea when we're trying to help somebody recover from an active flare. So those are some of the symptoms that people get. Sometimes people don't have symptoms at all. And so that becomes even more dangerous because they have no idea when they're having a flare. A lot of people.
So Steve, we're hearing every other word.
Pediatric uveitis, JIA, related uveitis, specifically, most is active. And so they have to.
Dr. Anisi, I think we're going to have Dr. Gonzalez take over because we're hearing
have regular
every other
exam.
word. Okay. Dr. Gonzalez?
Yes.
Despite how they feel, to make sure that nothing. And the last thing is I talked about.
Okay.
Okay, well, let me introduce Dr. Gonzalez.
Okay.
Then we'll have him take over. So I think if you just keep a footnote that he was talking about symptoms and those that are asymptomatic, and especially those little kids with juvenile idiopathic arthritis who are asymptomatic and the problems that brings. So I will go on to introduce Dr. Gonzalez, who is a uveitis specialist as well as a vitreoretinal surgeon at New Jersey Retina in Northern Jersey. He completed his ophthalmology residency at the University of Pittsburgh Medical Center, where he also served as chief resident. He did his vitreoretinal fellowship at Weill Cornell Medical College in New York. He completed a 2-year fellowship in uveitis and ocular immunology with Dr. Foster at Mercy. During these 2 years, he worked on diverse projects, including the symposia in birdshot, chorioretinitis, and childhood uveitis, as well as in diagnostic therapeutic approach of scleritis. Dr. Gonzalez also treats all forms of ocular inflammatory diseases from the front to the back of the eye, but with a big focus on the back of the eye. He's published and has held academic appointments, serving as instructor of ophthalmology at Weill Cornell. And we're super grateful to you for popping in and taking over for Dr. Anisi. Thank you so much.
Well, no, thank you so much for having me. It's an honor to be here and seeing so many familiar faces. So taking on where Steve left regarding symptoms, symptoms of uveitis can be very, very varied, and it could go from asymptomatic, especially in kids, to very symptomatic with complete visual loss and pain and redness. So we tailor the approach on follow-up and treatment and diagnosis depending on these disorders. For example, kids diagnosed with arthritis, they must have follow-up with a uveitis specialist every 3 months, regardless of symptoms or no symptoms. Because if we catch the disease on time, then we can save vision. It's a little bit different with adults that have arthritis because uveitis in rheumatoid arthritis is a little bit more symptomatic, and the adult patient can voice those symptoms and come to the eye doctor. Causes are many. Francis was mentioning about 85 different causes, and I would say approximately 30% of the cases after extensive laboratory testing, imaging, and even biopsies come back as what we call idiopathic, meaning that we don't know a particular cause and we cannot give a last name to the disease, but we know is a autoimmune disorder, and then we can play or we can work with the different pathways that elicit inflammation in the body to control the inflammatory reaction. And with that said, I want to move forward to getting the diagnosis. So Francis mentioned a phrase that I like a lot, which is to the front to the back of the eye, from the front to the back of the eye. So the diagnosis of uveitis has to be very systematic. You need to get the vitals of the eye, visual acuity, color vision, pressure of the eye, because these things can tell a lot on the type of uveitis you might have. After that, you have a full workup, checking the eyelids, the conjunctiva, the sclera, the cornea, then the front of the eye, the iris, the lens, the gel of the eye, the retina, the choroid. Every single anatomic part of the eye you have to examine, and it will be examined by your uveitis specialist. And depending on the findings, you can start in your head or in your records, you start doing a checklist of the positive findings and negative findings, and you can start narrowing down the type of uveitis that you have. Once we have the full exam, then we can get a lot of information just for the exam, even without labs. Sometimes we can even, I remember a lot when I was in training with Dr. Foster, he diagnosed just by looking at the slit lamp, very rare disease, just in five seconds. And he said, this disease is so particular that is the only disease that gives you this finding. And it was true, like he did the confirmatory testing and he proved. And there are diseases like that. There are diseases that are really quick to diagnose and very easy to find and guide treatment. And unfortunately, there are others that are more difficult to narrow down and get a final diagnosis. So one of the things that I usually talk to my newly diagnosed uveitis patients is do not despair, don't give up. Sometimes we do hundreds of blood tests and they come back negative. And that's a good thing. It's a good thing not to have tuberculosis or not to have lupus or rheumatoid arthritis. And it's positive findings to be able to tailor your treatment. And there are other diseases that will take time to manifest. And sometimes they start manifesting with scleritis, for example, inflammation of the white part of the eye. And then as time goes by, then it involves the front of the eye or the back of the eye, and that gives us more information. There are a lot of things that we can gather from what in medicine we call the review of systems, or a full medical history, including social history, including where you live. Doing a Lyme test in someone who's from Utah might not be much benefit, but in the Northeast is very, it yields a lot of information. And there are a lot of diseases like MS, birdshot in the north compared to the south of the U.S. It differs a little bit. So having there's a questionnaire that is available for everyone at the uveitis.org webpage, and bringing that questionnaire to your uveitis specialist or to your ophthalmologist is of utmost help in trying to narrow down the diagnosis. Obviously, there's a lot of blood tests and a lot of imaging that can be done to diagnose uveitis. There are patients that if only the back of the eye is affected, then you will get specific genetic testing or infectious testing. But overall, the idea to be able to start treating uveitis right away is to rule out infectious diseases. The reason being that an infection by shingles virus or herpes virus or toxoplasmosis can quote unquote eat the eye really quickly, and you have to protect the eye from those infections. So sometimes I tell my patients, you have to think about uveitis in two ways. From one pathway, we're trying to find your diagnosis. From the other path, we're trying to treat so you don't lose vision. And sometimes these go hand in hand. And sometimes we're treating and doing research, and then those pathways will cross over later in time. So we protect the eye with medications that quiet down the inflammation rapidly, or if we are not 100% sure, we don't have the labs to rule out infections with antivirals and anti-toxoplasmosis medication, which are the most common rapidly sight-threatening diseases, while we wait for the labs. The treatment of uveitis is a step-ladder approach. We start with, once we rule out infections, and we're talking now only about autoimmune uveitis, steroids are the fire department. We said uveitis is like setting on fire the eye, and all of the immune system acts in different ways and attack your own eye. So steroids basically blunt all the inflammatory response really quickly, and it allows you to buy time to be able to save the eye and start tailoring treatments. There are diseases that are very acute. They come and go, and they tend not to recur. So sometimes a normal course of steroids will quiet down the inflammation, and patient won't have inflammation again. But unfortunately, most of the uveitis tend to be recurrent, and they tend to require more treatment. And personally, I believe that here lays the main problem in treating uveitis, that we become hooked on steroids. So if you don't have a uveitis specialist, then you will be getting these courses of steroids over and over and over, and any form of steroids can cause significant side effects long term. Oral steroids can cause diabetes, Cushing syndrome, osteoporosis, and other, skin problems, cataracts, glaucoma. Eye drops in the form of steroids can cause definitely cataract and glaucoma. So the step-ladder approach to care of uveitis means to find a way to achieve complete inflammatory control without long-term steroids. So you use the steroids, you call the fire department to quiet down the fire, and then you need other medication to keep that inflammation in control. And the way I like to see it or explain it is the immunomodulatory therapy will train your immune system not to attack your own eyes. And once it learns how to function at a proper level, then you can come off of the immunomodulatory therapy. We like to call it immunomodulatory therapy, no immunosuppressive therapy, because the dosages that we use for this treatment are not the same as the ones you use for chemotherapy for cancers or oncology patients. So sometimes there's a little bit of hesitance to start treatment like methotrexate or Cellcept because of what we heard of other patients in oncology. But this is a very different dosages and a very different approach. For sure, all of these medications tend to depress the immune system, and for such reason, you need to be under close control and monitoring liver function, kidney function, and physical exams. So the step-ladder approach started with steroids. The next step would be oral NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs, such as Celebrex, ibuprofen-like medication that you can use for a longer period of time. If those don't work, then you can escalate to traditional immunomodulatory therapy, such as methotrexate, mycophenolate, Celsep, azathioprine, Cytoxan, chlorambucil. And then the next step is biologic response modifiers, which is these medications tend to, instead of completely suppress the immune system, to control different pathways. And a pathway is the route that the inflammatory or the immunologic system takes to cause inflammation. So you have the JAK-STAT pathway, which is the Clarity study. You have TNF, which is Humira, Remicade, and all of these medications. So these medications are great in control of autoimmune disorders. You probably have seen them on ulcerative colitis, psoriasis, advertisements on TV. And then there's higher levels of therapy, such complete blunting of the immune response, such as something we call cyclophosphamide or IV immunoglobulin therapy. And in this step-ladder approach, most patients will follow each one of the steps, right, escalating. But there are diseases that I have patients that I've seen them the first time, and it's like, we're gonna admit you to the hospital, you're gonna need IV steroids, or you're gonna need the strongest therapy right off the bat. Because we know those diseases not only affect the eye, but they can also affect the central nervous system or put at risk the life of the patient. But going back to the majority of patients with uveitis, we found through thousands and hundreds of patients treated for uveitis that the average treatment duration is about 2 years. 2 years to retrain your immune system, 2 years counting from the moment that you don't have inflammation and you're off of steroids. You start counting 2 years, and after 2 years, you can start discontinuing your therapy. And at that point, I believe, depending on the disease, is about 70 to 80% of remission. And remember, the goal of treating inflammatory disease is to achieve complete remission. There are exceptions to the rules. Some diseases require longer treatment, and some of them require a little bit less treatment. But I would say, in general, about 2 years. And the last thing that I wanted to talk about is specialists. Finding, I like to call partner in the journey of uveitis is very important. Finding a uveitis specialist that not only talks the talk, but also walks the walk is very important. Someone who is not afraid of letting you know the findings of the eye and letting you know how things are going, and not afraid of making decisions and refer you to the particular doctor if you get stuck in treatment. Sometimes that requires partnering with rheumatology. Let's say I don't have an infusion center in my office, so I partner with a rheumatologist to get Remicade infusions. I know at Mercy we have an infusion center, so that's an advantage, right? You can get all the treatment there. But finding a partner that can walk with you this journey of uveitis sometimes gets very frustrating. I mean, you're doing great, and then you have a flare, and then you're back to square one. And I will let you hear directly from someone who has walked that journey. But if you guys have any questions, I'm happy to take them.
Thank you, Dr. Gonzalez. I think that's a lot of information. And I think before we move along to support and coping, while we're focusing on diagnosis and treatment, I might turn it over to Taryn, if she doesn't mind, to just answer a few more of those questions related to the Clarity study in the chat, just to get those over with, where everybody just heard about diagnosis and the treatment step ladder approach. Where does that JAK inhibitor fit in, and answer some of those questions that are in the chat about who is applicable for the study, what is the inclusion criteria for the Clarity study.
Yeah, sure. Thank you, Francis. And Doctors Anisi and Gonzalez, if you want to jump in at any point, especially when we're talking about the pathway, you are most welcome to. But I'll try to keep these answers relatively quickly because we definitely want to hear from Andrea and Mia. So Jose had a lot of really good questions. The first one was, what is the endpoint of the study? So one of the key questions that the Clarity study is asking is, does brepocitinib improve the time to flare? So like Dr. Gonzalez mentioned, for a lot of folks living with uveitis, eventually it will flare again. And so the Clarity study is designed to compare people who get the current standard of care for uveitis against people who receive the standard of care plus brepocitinib, or the investigational medicine. The hypothesis or the theory is that if you are taking brepocitinib, that you will go longer periods of time before your uveitis flares. I want to be very clear, however, that this is still under investigation, right? In the United States, the only entity that can say that a medication is safe and effective is the FDA. And clinical trials are how you get the data to not only show the FDA that your medication works, but also just to gather information on the disease state here in uveitis in general. And the science behind it. So while we certainly hope that brepocitinib is helpful for people living with uveitis, it's all part of the process, right? I think it was Edison who said, I failed 100 times to make a light bulb, but now what I know is 100 different ways not to make a light bulb. It's kind of the same thing. Like, there's a lot about autoimmunity that we don't know yet. And studies like this help us learn. So that kind of answers your second question, Jose. What are the patient characteristics? This is where it's fun. So the protocol or the rules for a clinical trial tend to be in the hundreds of pages. That is part of why I have a job. You do not have to be an expert in the science and the eligibility of the Clarity study to figure out if you participate. That's my job. And I'm going to try to bridge that for you in a very accessible way. So I have a set of questions that I will walk through with you. And based on your answers, I may ask you some additional questions. We may look at your medical records together, those types of things. But every bump in the road, I'm here with strategies to help you get the information that we need to help figure out if you're eligible and you need. That said, some of the key criteria are you must be an adult, so you have to be between the ages of 18 and 75. You do have to have a diagnosis of non-infectious uveitis of the middle part of the eye, the back part of the eye, or the entire eye. So one important point is that people living with only anterior uveitis, so that very front part of the eye, those folks are not eligible for the Clarity study. It's not uncommon, actually, Dr. Gonzalez or Anisi may jump in here and correct me, but in my experience, the people that I'm chatting with about this study, it's not that uncommon for somebody to start with one type of uveitis and then other parts of the eye become affected. So Dr. Gonzalez, do you want to jump in there and comment one way or the other?
Yeah, so it depends, but in idiopathic uveitis, especially I've seen cases of scleritis. They start with the scleritis, diffuse anterior scleritis, then they develop also anterior uveitis. But it's not unusual to have patients with uveitis diagnosed first as anterior or intermediate, and then develop extension to another part of the eye.
Thank you. Yeah, so that's why I say, if you're not sure if the study applies to you or not, please talk to me. I mean, I'm going to be friendly, I'm going to be kind, I'm not going to bug you unnecessarily. I just want to help you get the answers that you need around the study. You can be newly diagnosed. The caveat there is clinical research is definitely not for everyone. And you, as a human being, and your sight are more important than any clinical trial. So I would say it's probably unusual for a person who's just been diagnosed to participate in any clinical trial, because you need to get the uveitis addressed and under control. And a clinical trial probably wouldn't be at the very forefront of your treatment options. But that can also be looked at on a case-by-case basis. So if you have questions, please come chat. And then what is the pathway? So Dr. Gonzalez touched on this briefly. Brepocitinib is what's called a JAK1, and here JAK is spelled J-A-K, and a TYK2, T-Y-K, inhibitor. So those two acronyms refer to inflammatory pathways that everyone has in their body. But the thought is, in certain autoimmune conditions, it's like those pathways and the inflammation that's part of them get too loud. Doctors Anisi and Gonzalez, would you agree with that description?
Yeah, I
Yes.
think so. You can hear me, right? I think now, right?
Yeah.
That's kind of what I was alluding to earlier. There's certain parts of the immune system, they become overly active, and you need to down regulate them. It doesn't mean it's not going to be working,
Right.
but if they're overly active, they need to be suppressed to a certain extent where they no longer cause the irregular overactive damage that they're causing to parts of the body that they shouldn't be doing. So Janus kinase and tyrosine kinase, JAK and TYK, are two enzyme pathways that get downregulated by this medication. It's the only medication that actually activates or inhibits both of those pathways at the same time in all the pharmacology that we know of right now, which is really exciting. And they help to suppress a large amount of inflammatory signals that help propagate a lot of the types of inflammatory diseases that we see. In short, they stop a lot of things. And it's nice because it's a pill, it's not an injection, and it's not IV, something you can take at home once a day. I mean, if this comes through the way we believe it will, it'll be a very, very nice addition to the types of things that we use to treat our patients.
And like Dr. Gonzalez mentioned, steroids do a great job at turning down all inflammation at the cost of some pretty significant side effects, especially if you have to continue taking them long term or using them in the eye long term. The hope here is that brepocitinib is like a very focused way of turning down the inflammation where we need it, while leaving some of the other parts of the immune system alone. So those are the questions. I think we're good, Francis, to pass off to the next speakers.
Awesome. Thank you so much. That was great. And I'll just go ahead back to screen sharing. And now I'd like to move along to our support and coping. I'll introduce our patient and caregiver team, Andrea Batistas and Mia Resendez. Andrea is the mother of Mia. Andrea is a foundation board member, becoming involved after her daughter Mia was diagnosed with uveitis at the age of 12. Mia is a uveitis patient herself. She was diagnosed in 2012 and is currently in remission on therapy. Andrea and Mia, having been recipients of coping and support, have now been instrumental in patient advocacy and fundraising efforts for the foundation. They continue to speak on support and coping through Mia's journey with uveitis. And now I'd like to turn it over to Andrea and Mia, who will speak about support in coping. Thank you.
Hi, everyone. I'm Andrea Batistas. Mia is sitting next to me. We are on a journey in uveitis since Mia was 12 years old, and she's now 26. So she has been on almost every medication on the step ladder. that there is. And she's currently on a treatment of IVIG and rituximab and has been on that treatment for 3 years, perhaps.
Yeah, 3 years.
In the hopes of full remission. So just quickly, I'll let Mia take over, but how we cope. So it's a lot different now for us. When Mia was younger, I was kind of the person that was doing all of the coping for her. She was just on the journey as a young child, almost teen. We are very involved in fundraising. For us, that was very important. Getting all kinds of information about uveitis was extremely helpful, and having a physician or a nurse practitioner like Frances working with us was extremely helpful. So having someone that you can talk to about your journey is really important. There's so many questions with so many medications. It's really impossible to do with just the Google doctor. So having someone that you can talk to is really important. So the programs that OIUF offers are super helpful because they allow you to talk to other patients who are on the same journey that you are. And just learning about clinical trials, like the program that we're talking about today, and other things that are going on in the uveitis community is super important. And also, now Mia is older. When she was young, I don't know if any of you have young children with uveitis, but having them talk to other kids who are going through exactly what they're going through is super helpful. So for us, we have taken into fundraising. Fundraising is really important for us because it helps us feel like we're giving back to OIUF in the sense that we can maybe help fund research that finds a cure. So I'm going to let Mia jump in now because she's older now and handling everything on her own. I'm just kind of on the sidelines.
She's more than just on the sidelines. She's like my Bill Belichick. She is a huge supporter. So it's not just the sidelines, but looking at the bullets here, and I think the first bullet, how they cope, really ties into the rest of the bullet. So I can talk a little bit about that. Starting with something that's not on the screen, in terms of coping, is just using your voice and talking about it. When I was younger, that involved talking to my friends and teachers, but now it's talking to my boss and coworkers about doctor's appointments, infusions, things that I need to do outside of work to work with my uveitis. But in terms of the bullet points here, we have the pediatric conferences, which my mom has spoken at and attended many of, and Facebook groups, which is something that I'm involved in. And I think that's a great space because if you're not joining support groups or if you don't know anyone else with uveitis, this is really how you can connect with people. And I've reached out to people on Messenger, and I've had people reach out to me on Messenger about their uveitis and their journey. And that alone is a huge coping mechanism, just relating to others that have this rare ocular disease. Keeping up in research, as my mom said, it's an amazing part of, while rare diseases are not great, it is an amazing part of a rare disease. I think Taryn said earlier that when you screw in the light bulb, 100 ways not to do it. It's true. So I work in clinical research now, and I completely agree with that statement. You don't always have to get involved in research if it's not for you, but I encourage everyone to use uveitis.org and clinicaltrials.gov while they're up to date regularly, to look at research opportunities. And if you go into your doctor's office and they're doing any clinical trials, or if they're even just doing research on blood samples or whatever, I would encourage you to read the consent form or the protocol and see how you can help, because it's not always about how we can help ourselves, but how can we help others living with uveitis and those that may be diagnosed in the future. And finally, I do want to speak about the support groups because they are amazing. I remember back when Mercy was in Boston and Cambridge, and I would sit in the infusion chair, and I feel like Frances would run in or someone would run in and say, there's a support group going on. Do you want to join it? But I think most of the support groups are remote now, and they're still great because people are joining from the comfort of their own home, and they're able to share their story or ask others about their experiences. It's similar to the Facebook group where you can kind of mention things that have been going on and ask others how they cope, but it's good because you're kind of getting that face-to-face contact. Foundation activities as well, same thing. It's a great way to connect with others and share experiences and kind of just have someone to talk to about things you might be going through or your kids might be going through with new uveitis. Just scary sometimes. Anything else?
No, I think that covers it all.
Awesome. Thank you so much. We super appreciate it. And your feedback as a patient, as a mother and a caregiver, I think that's important. You know, this disease is a rare disease. And so, I mean, it's not only a rare disease, but it's hard to even pronounce. So, you know, you don't know anybody else unless you're in a waiting room and you meet other patients who have it. Sometimes you look normal, you don't have any disfigurement, so it's very hard for your family members or your friends to understand what you're going through. So here in the support groups, as Mia and Andrea mentioned, you find others who are going through your same journey and can understand it, understand what you're going through. And the nice part is that we have people in all different parts of the journey. So like Mia now, who's in remission, but on therapy, or you may have someone who's newly diagnosed, as we focused the meeting on tonight. You may have someone who's diagnosed and just going through the stepladder approach. So it's nice that we bring all those people together and we share experiences to help each other move forward and have some normalcy with living a life with chronic illness. I think, you know, ocular inflammatory disease is a chronic illness, and especially when you're moving along in life just fine, and then you get it in adulthood, and it changes your entire life between work and home. So, so we have a lot of resources between the education, the support groups, and then also our conferences provide not only the education, but the support. And then also Mia had mentioned our fundraising events. Like our walks are great because you're there with other people and their family members, and you can speak with them and understand how other people are getting through this journey with ocular inflammatory disease. Unfortunately, there's not a one treatment that fixes all. And so, you know, you have to move through that stepladder approach. And we're glad for Priovant Therapeutics and the Clarity study and what they're doing to add more and more to the treatments of uveitis, because that's extremely important for us to have FDA approved treatments that we can turn to, and new treatments all the time, because there's no one recipe for anybody to control the inflammation. So we're grateful. And with that, I'm going to open it up to discussion. I just have a few ground rules for a discussion. We want to focus our discussion on the present to move forward with our care. No criticism of healthcare providers or the past negative healthcare experiences. We ask that you not ask guest lecturers to diagnose or treat your case, and please stay muted until it is your turn to speak. You can either raise your hand for asking a question or use the chat as well. And I'll ask for Allison's help in finding the hands raised for questions. So I will stop sharing my screen and open it up for any questions anybody may have.
I think there's two questions in the chat.
Okay. So I believe the first one is Jose. Talking about cure, is there any uveitis cell therapy trial? Other autoimmunities are being studied with these cell therapies. And I think, Jose, you're speaking about the CAR T cell therapy?
Correct. I'm speaking about CAR T. Yes, thank you.
So I know I could turn it over to Dr. Nisi, but we have done some T cell therapy with Cartesian therapeutics, and they were done with two patients, one with autoimmune retinopathy and one with Dr. Anisi's patient with ocular cicatricial pemphigoid. And if Dr. Anisi has any Wi-Fi and can turn on his
I want to read it. Yeah, no, those are the two patients that we were able to bring through that trial. Both successful to date, incredibly successful. Both were able to come off a wide range of therapy and get past very difficult to control disease. So it's a very promising type of therapy. It's very difficult. It hasn't been used in our field very much to date. It requires a lot, so it's not nearly anything that's going to be widely available at all, but it's promising. And there's other cell therapies or types of things that affect the cell in a larger sense than just chemical signals that are trying to be studied as well, inflammasomes and viral vectors and things like this that are gaining traction. Gene therapy, actually changing the way that the cells code proteins and develop, trying to recode them from the beginning so that they don't produce as much inflammation. There's a lot of that stuff that's starting to be looked at more and more. Nothing, again, that's, I think, widely available, but it's all being looked at some point somewhere. So in the next several years to 5 to 10 years, you're going to probably be hearing a lot more about that type of thing.
Thank you.
And just for those who don't know, the T cell therapies, they remove your T cells through plasmapheresis. They re-regulate them, so they tell them to stop attacking your body, and then we infuse those new re-regulated T cells back into you to hopefully retrain your immune system to stop attacking itself and stop the inflammation. Basically the same sort of theory that happens with immunomodulatory therapy. So immunomodulatory therapy, again, we suppress your immune system, so that stops it from attacking itself. And then we find after doing that for 2-3 years, the immune system actually re-regulates itself on its own. So back to our questions. We have a few more in the chat. We have a question about the role that diet plays. Is there any specific anti-inflammatory diet study going on one should follow, or a diet one should follow? Dr. Anisi or Dr. Gonzalez?
I don't tell people to do anything specifically. There's a few foods and things that people enjoy that are sort of well known generally to be pro-inflammatory without going into mechanisms, because I'm not sure I really could to a large degree. But things like sugars, lactose, and gluten are three that come to mind, all the good things in life. I've had patients tell me that they've gotten rid of these things in their diet with success in helping to downregulate their immune system. However, I never ever introduced that as a way to do anything for my patients, because the other thing that it introduces then is stress, in the way that you have to avoid foods that are comfort foods that, even if you do them in with some control, self-control, are nice to have, and completely cutting them out of someone's life can introduce other forms of problems like stress, and which I believe can also trigger flares. So it's a balance. If you're willing to try some of those things and cut some of those things out of the diet, I know that there's resources out there. I don't know anything specific, but I have had patients have some success in making their immune system or their inflammatory disease more easy to treat. That's about as specific as I could get with that question. I don't know if Luis, you have anything else to add?
No, I agree with your statement. I mean, diet clinical trials are extremely difficult because it's very difficult to tally what exactly amounts and what you're eating. I would say, there's some link between ultra processed foods and gluten and inflammation. We don't know to what extent it plays a role. I tend not to put that burden on the patient, because even with that diet, most of the time the autoimmune process is ongoing, and you will require another stronger therapy. but it couldn't hurt. The other thing that I also mentioned is supplements, right? Supplements are widely available, pro-immune system or boost your immune system, and we really don't know how they work. So I try to recommend my patient not to take high doses of ginkgo biloba or these medications that we know will boost the immune system. We're trying to quiet down the immune system a little bit instead of boosting it. But again, like, we don't have formal clinical trials side to side to see the effect of these supplements and dietary contents.
And one of our fellows did do a study years ago with gluten deficiency and uveitis, but we didn't find any. We found people with uveitis had gluten deficiency, but nothing was causal. So we didn't see that gluten deficiency caused the uveitis. I think a lot of our patients like to follow, like anti-inflammatory diet, and that's okay. It's an adjunct therapy, but again, like Dr. Nisi and Dr. Gonzalez said, that also can be a burden and add stress. So do whatever makes you feel good, because there is definitely a correlation of stress and inflammation. And then moving on to our next question, Elizabeth asks, do you have to be in a flare for a doctor to get to the root of the cause? This is coming from someone who's had 2 flares in the last 4 months, and I will leave it. It shows a second part of that question, but we'll stop there and have Dr. Gonzalez or Dr. Nisi answer that.
I mean, I don't think it's necessary to be an acute flare to diagnose the root cause. Sometimes uveitis leaves some scarring behind, and it's telltale when we see this. It helps to see it active, because you can classify and anatomically where the uveitis is. When you have 2 flares in the last 4 months, the question comes to mind: is it the same episode that never went away, or it went away and it came back? So a full review of systems, the past medical history and the features or characteristics of the flares would be really important to be able to get to the root cause. But remember, like, uveitis sometimes is not diagnosed at one point in time. Sometimes it's over time that is manifesting, and you can actually see what's going on.
Thank you, Dr. Gonzalez.
Yeah.
Dr. Nisi, can you just add to that with ocular cicatricial pemphigoid, and also maybe some of the posterior uveitis where you want some cells there if you're going to do any diagnostic vitrectomies? So I think they fall outside that.
Well, flares certainly help. I mean, it really helps to be able to see what's going on. But I have to agree with Louise. It's not necessary all the time, because, and this is one thing I try to make sure that our fellows at Mercy know, that the first thing I want to hear when I see a new patient is when their problem started, how they felt. Because if you hear it in the own words of the patient, I can almost tell exactly what they have by the time I start looking at their eye, a lot of the times, just because of the story, how they responded, at least to a general degree, and sometimes very specifically. And it's very important hearing the symptoms, because that'll help you to narrow down different things as well. But seeing the inflammation really helps. So with respect to what Francis was talking about, if you see active inflammation, that can help you direct diagnostic studies. For example, if we do a biopsy, if the eye is completely quiet, taking a biopsy to try to figure out what's going on is not going to be very helpful. The yield, what we call it, of doing that is going to be very low, because inflammatory cells, those types of processes aren't going to be as active or apparent when the pathologist looks at the slides of the tissue that we give them. Infections may not yield a positive culture, things like that. So it's nice to have, for the person trying to assess a new problem, the active problem in front of them at the time. And so a lot of people will send people to our clinic. A lot of doctors will send people to our clinic and ask them not to use their medications for a few days so that their condition kind of gets worse, not because they're being mean, but just because they want it to be an active process so that we can see what's really going on and then direct the therapy and the workup after that.
Excellent. Thank you so much. And then the second part of that question was the names of Facebook groups you found helpful. So we have, and you can find on uveitis.org, if you go to patients and support, you'll find our link to our Facebook support group pages. And so we have one for adults, one for teen, and one for parents. So that's what we're speaking about in regards to the uveitis. In regards to the support groups that are online, they are under Facebook. And I think there you can, post questions, you can give your story, ask for people's advice about medications. Some people talk about studies there. So people just ask questions about their care, and you have a great group of people in different parts of their journey that share their experiences. And that is super helpful for education and support. All right, and moving along to the next question, which has a few typos, but I think I can work it out. So I think it's regarding, which is a great question, when you have uveitis and you have a related systemic disease, and in this one, it's inflammatory bowel disease. And I think they're asking, are those diseases sort of linear? So if your uveitis is flaring, is your inflammatory bowel disease flaring, or do they flare separately? And, how is that correlated? How is treatment correlated with treating both together?
They're not always correlated. That's something that we know through various diseases. For example, GIA uveitis very commonly can have one part be active and one part be quiet. Joints active, eye quiet, or vice versa. And similarly, you can have medications that help one part of the disease and not the other. So I always ask about both things when I see patients. I make sure that their eyes and their joints are both behaving with whatever we're giving. And sometimes one will drive, one feature of the disease will drive the treatment process where the other will not. Some of our patients that we aim to get off medications have been, doing well enough with their uveitis for a long time, but their joint disease is out of control. And so they continue medications longer than we would have continued them because of the need to treat the other part of their disease. So not always going to be lining up with each other. Oftentimes do, but not always.
Awesome.
Yeah.
Thank you. I'm going to move along to the next question, which is a fabulous question. How long is a patient typically on steroids before moving to immunomodulatory therapy as the next treatment option? And I know, Dr. Gonzalez, you touched on this. You spoke about it in your talk.
Yeah.
Maybe you can just give the specifics as to how that stepladder approach moves along.
So it depends also on the type of disease. There are certain diseases such as VKH or Persia that we know the patient will require immunosuppressive therapy, almost 100% sure. So we start moving actually at the same time. You start with high dose steroids in taper, and at the same time you're starting those steroids coming down, you start kicking off with the immunomodulatory therapy. So by 8 weeks, 10 weeks, patients off of steroids and it's already full dose immunosuppressive therapy. There are other instances such as intermediate uveitis that we have a little bit more leeway on treating with steroids and taper down and off and see if the inflammation recurs in the way of oral steroids or periocular steroids. There are also more recently other avenues of treatment with intraocular steroid pellets or implants of steroids that in ocular, an inflammatory disease that is limited to the eye can be of choice as well when the patient cannot take immunosuppressive therapy for other systemic conditions. But I would say once you're diagnosed with autoimmune disease of uveitis, I would say within no more than 6 months on steroids, and I would say for me on average is about 3 months max on oral steroids or on topical steroids. I don't know about you, Steve.
I don't like to use them very long at all. 3 months is kind of a long time for me. To be honest, I actually try to avoid them if I can, because there's a lot of people who really don't like being on them. And if I don't have to use them, if I can do something local or otherwise, or if I think the medications will act more quickly, then I'll do that. But I will start them if I need to. And I'd say that most of the time my tapers are probably over by 6 weeks. That's pretty common for me. There's a lot of other specialists who use them a lot more liberally and a lot longer time. They have sort of a higher threat or a higher tolerance for steroid use, but that's classically been the MO of our teaching in our way, is that we're trying to avoid them as much as possible. Great for putting things out, but getting off as quickly as possible. And for diseases where we know, things that look severe, things that cause scarring immediately, we want to get those people on the medications right away that we know that they're going to end up being on, so that they can stay off the steroids.
I also must say that at least for Steve and I, most of the patients that we see have been treated already with steroids. So by the time we see the patient, there's been already several courses of steroids. So I agree with Dr. Nisi I usually taper within 6 weeks, and at that point, sometimes I linger a little bit longer if the inflammation or the other medication is not fully on full dose, but limit the time on steroids and starting immunomodulatory therapy helps a lot.
Exactly. So next question. I was diagnosed with EMR 6 months after cataract surgeries. Upon further examination by a uveitis specialist at Mayo in Rochester, I was diagnosed with uveitis later that year in 2014. And the question is, can the scar tissue of the retina be removed if someone has uveitis? Dr. Gonzalez?
This looks like an epiretinal membrane, probably, right?
Epiretinal membrane, yeah, it's an epiretinal membrane, and yes, it can be removed. Depends a lot on the status or the stage where the uveitis is. It has to be in remission for at least 3 months before any intraocular procedures. There's if you're on therapy, there might be some modifications to the therapy or the perioperative treatment to avoid inflammation. I must say that epiretinal membranes that are secondary to inflammation tend to be a little bit more or thicker, or I don't want to use the word aggressive, but they tend to be thicker and stickier than the ERMs or the epiretinal membranes that are due to the aging of the eye. But it depends on the testing and the chronicity of the membrane. It could definitely be considered.
So if you've had it since 2014, is it still operable?
Yeah, I mean, you can operate, but the problem is depending on the stage. There's different stages of the retinal membrane, is what to expect, right? The expectation of how much vision you're gonna get back. If it's a very advanced membrane that has been there for many years, maybe the risk versus benefit is not worth it. But if it's a relatively thin membrane with not a lot of distortion and it just started becoming symptomatic more recently, then it might be beneficial.
Excellent, thank you. We have 4 more questions, and that will be the last of the questions since we're already over time, but it's been a great meeting. So the next question is very interesting. Is uveitis a familial disease?
It can be. There's several diseases that run in family, genetic diseases. They're rare, though they're rare, and they tend not to be. Let's say you don't have anterior uveitis, and everyone in your family will have anterior uveitis. There's a form of sarcoidosis that is familiar. I usually presents in early life. What I've seen, and I think is more important, is autoimmunity tends to run in families. So if you have a family history of rheumatoid arthritis here and lupus there and another autoimmune disease, then it can definitely be that you're more prone to this type of disorder.
Dr. Anisi, do you want to add to that?
No, I mean, not really. There's, like Louise said, you may be more or less prone to something based on your genetics, but doesn't guarantee that you're going to get something.
So like the HLA-B27 gene, I mean.
Yeah, that's a common gene. That's in 9% of Caucasians, but not 9% of Caucasians don't have autoimmune disease, much less uveitis. So it just puts you in a position where you may be more prone to developing it, and that percentage of being prone to it, your risk factors for it is variable. But I tell people, don't hold your breath that you're going to get a problem just because a family member gets it. I think that's a good way of putting it. If you're counting on it, you're probably going to be disappointed. So.
And then the next part of that is, do hormone changes during life cycle impact disease and its remission? And I think that's been well studied that there is some correlation with menstrual cycle and flares, and also hormonal changes with menopause triggering inflammation. But I don't know if either of you want to add to that.
It's not something that I think I probably see as consistent. Well studied, it probably is. I'm not as familiar with some of it. I think that there's been data that's showing that there's an increase in the incidence of flares maybe later in the menstrual cycle. And then in women during pregnancy, it tends to be downregulated. The immune system is downregulated. So in that respect, hormones can change things, and then after pregnancy, the immune system goes kind of back to where it normally is. So about 6 weeks afterwards, we see people start to flare if they're going to. Other people who are on hormonal therapy, I'm not as familiar with some of that, but I don't tend to see it play a big part in the patients that I see. I think the variability is so large that I couldn't point to anything being specific.
Yeah, so I think, you bring up a great point, and that is, it's not consistent with every female patient that is still with their menstrual cycle, that they all get flares during certain parts of the menstrual cycle. It has been noted, but that doesn't mean that everybody gets a flare around their hormonal changes. So great points. So next one, are you talking about oral steroids now or oral drops, not wanting to give them longer than 6 weeks? So I think that's
oral steroids, really, but I mean, you don't want to be on drops either. There's so-called low-dose steroid, whether it's drops or pills. I don't believe it's possible to achieve what we call a cure or long-term remission off of medications at all if anybody is reliant on steroids. I just don't think it exists. Now, different people have different tolerances for that, and depending on each person's journey, it may be okay to actually use them if somebody's gone through every single drug in the book and they have severe disease and 1 or 2 drops keeps them under control, and they're sometimes it's okay, but really the overall goal is to get people completely off steroids as quickly as possible, especially when they have certain things like a steroid response. Their pressures go really high, or if they have bad cataracts, or if they're taking oral steroids, people with diabetes or osteoporosis, they're at high risk for developing complications from those problems. So we want to get people off as quickly as we can. The numbers we gave before, just kind of generally how long I end up using those medications for, but shorter if possible.
And I think, Dr. Foster always emphasized, and I think it's been, published in all the works that remission, it's on you're in remission on immunomodulatory therapy off steroids. Like Dr. Anisi said, if you're on immunomodulatory therapy and still on steroids, that's not going to equal durable remission. You really do have the steroids off. And the whole point of immunomodulatory therapy is to be in remission, not have to use the steroids, because I'm not sure that we didn't really emphasize the side effects and consequences of long-term steroid use, but maybe either Dr. Gonzalez or Dr. Anisi wants to just go through that and the whole point of why we limit that use of steroids and just use it to put out that fire.
Yeah, I think Steve put it really nicely. Is we don't think the steroids will depress the whole immune system, but you will not retrain your immune system or modulate the immune system to stop attacking your own eyes or your own body. So the long-term consequences of steroids are horrendous. You can have fractures from osteoporosis, diabetes, Cushing syndrome, cataracts, glaucoma. Some of them are irreversible even when you stop steroids. So the whole idea or the whole mission of achieving remission and inflammatory control is to be able to be off of therapy eventually. And with immunomodulatory therapy, we know we can achieve that in the long term. And I'm just going to take a moment to answer Brianna's information. So a question, yes, I mean, there's a very specific definition for what's chronic and acute. But if you've been having an episode of uveitis for more than 3 to 6 months with no complete remission, then it's chronic. Or you have several episodes that come and go, then it becomes a chronic problem. And yes, it's okay to use the language remission, because that's what we say. The mission is remission. The mission is to achieve the control of the inflammation. And remission is equal to cure, right? Remission is when you're off of the steroids. You can be in remission on therapy or in remission off of therapy, and it means no inflammation.
And Dr. Nisi, can you just add to that and talk about those patients who maybe have like an acute case of uveitis versus those where we would put in the category of chronic illness when you have like recurrent inflammatory attacks?
The definitions of those things, for research purposes were put down by a group 20 years ago, just so that doctors could be more specific in research. But I mean, something that's acute is happening right now. Something that's recurrent happens, but has intermittent times when it's quiet. And then something that's chronic is something that continues to be a problem despite, maybe even trying to treat it. So that's where you get the different terms. There's a lot of chronic disease out there that gets put into remission with the appropriate therapy. It still is a chronic disease. So the language is variable. It kind of refers to the severity or the type of disease. And sometimes just certain disease states can be a chronic disease that has an acute flare. So you can see that the terms more or less affect the overall activity of it, or just the nature of it, the severity of it. We use those different terms to discuss various stages of the disease sometimes, not just the disease itself. But anybody with chronic disease that's going on and on and on despite addressing it, those are definitely things that you want to address and try to, those are the people that are steroid dependent, and those are the people that we almost always, talk to about medications, immunomodulatory medications, to get them off of the steroids and get them into remission.
Awesome, thank you. And our very last question tonight, a great question. So since, ocular inflammatory disease is associated with systemic causes, and if you had a systemic condition, they're asking, is it best to establish care with a uveitis specialist who is in a larger hospital system rather than an independent provider? So I think that Dr. Anisi, you want to pick that up?
It really depends. I mean, I think that Mercy is one of the best places in the world to receive care for all types of ocular inflammation, and we are not affiliated with any hospital system at all. Much like people think that we're Mass Eye and Ear, we are not, because the names are kind of similar. We're definitely not. And it just depends on the doctor. I mean, you have to look at who the doctors are, what their training was, who's recommending them. Does your doctor know who they are? And do they have experience with other patients that use that doctor? Are there stories about them online? Sometimes they're good and sometimes they're bad. It can be hard to know. But I would say that, what you probably want to do, academic centers tend to have the people that are more experienced and know these things, but it's not going to be an absolute, especially in our case.
And I think too, Dr. Gonzalez is also in an independent practice.
Yeah, and I second that. I mean, it's depends on where you are, depends on the hospital system. Sadly, uveitis specialists, there are not a lot of us, so not all of even the larger hospital system have a uveitis specialist. So, for example, the area where I am in northern New Jersey, there are at least I know 3 former fellows of Dr. Foster. All of us are independent, and the largest hospital systems, we serve them, and sometimes they call us to participate in the care of patients. But yeah, it depends a lot where you are, and as Dr. Anisi said, doing a research on your hospital system, who's the uveitis specialist. There's a whole list of former fellows from Dr. Foster and uveitis.org that you can access, with like fellows from all over the world in the US by states, and you can also reach out to the OIUF for more information on recommendations as well.
And I think the key point there is to, just have a uveitis, ocular inflammatory disease specialist, so someone who has had a fellowship in ocular immunology is key. And then I think the support groups are great because, as I can't remember if it was Dr. Anisi or Dr. Gonzalez who said, there are uveitis specialists who talk the talk but don't walk the walk. So basically, you want somebody who really knows that stepladder approach to care, can really move you through that stepladder approach to care. Don't get stuck on one therapy and steroids. That is not the goal of treatment. That's not the goal of the stepladder approach to care. So just having that uveitis specialist who can treat you, and remember that just because you're an independent provider doesn't mean that you don't have a referral system. So, we have a whole referral system. So if we feel you need a rheumatologist, you're referred to a rheumatologist or a gastroenterologist or anybody else who's going to be needed to help with that care. And also a lot of the uveitis specialists, independent or at hospitals, some of them don't manage their own chemotherapy, so they're going to be collaborating anyway. But we have a whole referral network. And so I don't think you need that larger institution to get all your care to address your systemic and your ocular inflammatory disease together. But I really want to thank Taryn and Privant and the Clarity Study. This is what we need. We're a rare orphan disease. Like we said, there's no one recipe. So the more FDA approved medications, immunomodulatory therapies that we can get to treat our ocular inflammatory disease, the better, because there's not one drug out there that gives the cure. So we're grateful that you're on board and trying to find yet another therapy to put us in remission. So with that, I want to thank Dr. Gonzalez, Dr. Anisi, Andrew and Mia, and all the participants, Allison and Yasmin, everybody who's been here tonight. Thank you for taking the time for the meeting. And Taryn did post her information in the chat, but if anybody has any questions, please feel free to go to uveitis.org. You can find information about the study there. You could also email Allison. So thank you so much and have a great evening, everybody.
Thank you, everyone.
All right, good night.
Thank you.
Good night.